Good afternoon and welcome to today's presentation, Making Hybrid Service Models Work Better by Leveraging Pharmacy Services. Today's executive web briefing is brought to you by Open Minds and sponsored by Genoa Healthcare. This afternoon, I am joined by Jeff O'Neill, President and CEO of Greater Cincinnati Behavioral Health Services. Jeff has worked in the field of behavioral health for over 29 years, leading and directly working at all levels, including residential treatment, housing, care management, counseling, and integrated care. Dr. Scott Hedges, Chief Medical Officer and Director of Laboratory Services for 7 Counties Services, Inc. Along with this, Dr. Hedges also serves as clinical faculty with the Department of Psychiatry and Behavioral Sciences at his alma mater, the University of Louisville School of Medicine, and is a consulting psychiatrist for St. Luke's Institute, their Louisville office. And last but not least, there is Kevin O'Neill, Vice President of Sales for Genoa Healthcare, who has also been a licensed pharmacist in Rhode Island for 20 years. So during our time together, all of our panelists are going to be covering how their clinics are addressing the shift to value-based care and delivering on the promise to hybrid service systems. You may notice that all of you have been muted. That's because we're recording today's event, and muting the phone lines assures the highest quality of sound for that recording. We're also going to be sending out a link to the presentation, slides, and recording after the event. So just be on the lookout for that within the next few days. And we do encourage you guys to submit questions at any point throughout the presentation using the questions box on your GoToWebinar panel. So with that, I will turn things over to Kevin.
Great, thanks so much. Good afternoon or good morning, everyone, depending on where in the country that you're joining us today. I'm super excited to be here today with Jeff and Dr. Hedges talking about how hybrid models can work better through pharmacy services. We thought it would be fun today to start off with a poll to see where everyone listening, where exactly they are with their services in their clinic setting. So if we could launch the poll there on the screen, please choose one of the options. How is your center operating? Is it currently in person? Is it a hybrid model, or is it completely virtual? So go ahead and choose one of those options. All right, can we see the results? There we go. Well, it's as we had expected, and why we're having the conversation today. 88% responded that there is a hybrid model. We can move to the next slide here. So today we're going to talk about some of the trends that we're seeing in this new hybrid world, and really the ongoing shift to value-based reimbursement and how pharmacy services can really help your organization get where they need to be. So let's move to the next slide, and you can see why those poll results were not a surprise. So pre-pandemic, we saw that 0.01% of visits were delivered virtually. And we had to obviously rapidly change the landscape to accommodate the pandemic. So in the first quarter of the pandemic, 80% of behavioral health visits were delivered virtually, with 70% of primary care visits being virtually delivered. This just shows that there's crisis-driven rapid acceleration of virtual service delivery, and we have to adapt to it because consumers are now used to it, and so they're going to expect to have services both in the clinic, in their home, and virtually as well. So let's move to the next slide. And we wanted to say that there's also an increase in value-based models. So we used to say value-based contracting, value-based models are coming. The truth is that they're already here. And we're expecting them to increase. So as you can see, 36% of all healthcare payments in the US right now are value-based, with 53% of specialty provider organizations participating in some sort of value-based reimbursement program. The global value-based care program is expected to grow from $1.52 billion in 2020 to over $4 billion in 2025. So if you haven't been thinking about how you're going to prepare for value-based programs, now is the time to really start doing so. So that's what we're going to lead our discussion in today, and we do want this to be very discussion, conversational based. So if you can move to the next slide here. What we really want to talk about today is how are we going to navigate these complexities of value-based relationships? How are we going to navigate a hybrid model to make sure that your clinic maintains consumer satisfaction, that you demonstrate positive outcomes, and that you stay competitive in a diverse market? So we've teed up some questions for our panelists here. So I'm going to let anyone jump in on this one, and I'll start it off with, how has your clinic navigated this shift to hybrid care? Who wants to take that first? Jeff?
Go ahead.
Yeah.
So in our clinic, we've attempted to navigate the shift to hybrid care in a couple of different venues. So most of our outpatient services, both whether it's therapy services or even prescriber services, are largely done via telemedicine in some capacity, but other kinds of services are done in face-to-face services. So our ACT teams, our case management services, our medical detox, these are all face-to-face services. And we've done a pretty good job of managing those over the course of the transition with the pandemic. It's been helpful because we've had a close connection with our health department here in town, which helps us monitor how our community is doing specifically. We have all the way down to the county information in terms of infectivity rates, and that makes it a little bit easier for us to kind of navigate through that process. The key issue for us is trying to make sure that we have solved the issue of maintaining connection with individual patients or individual clients, consumers, as they continue services. So it's simple things that sometimes can stand in the way, making sure that you've got your appointments scheduled, making sure that you're being able to pick up your medications, making sure that your reminders are coming through, trying to figure out how to navigate the electronic options, whether it's on your phone for the clients, whether it's on their phone or their iPad or their computer, and having access to that. We've even built out some rooms in some of our locations so that if a client doesn't have access to the technology in their own personal sphere, they can come to us and still connect with any of their care providers via a remote session in a safe and health environment. So that's proven to be very effective for us as well. Jeff, what are your thoughts?
Very similar, Doc. Like everyone, we were certainly faced with the daunting challenges at the beginning of COVID. Certainly, a lot of fear and uncertainty. How would we continue to engage many of our clients in critical and essential services, as you've outlined some of those? And just for some context, our organization is heavily rooted in serving the deep end, folks with the most severe mental illnesses and other barriers. And so while the advancement of telehealth was a tremendous solution for some, many of our folks, it was not feasible for. And of course, that gave us great concern. These individuals are already very isolated, as we all know, and really challenging to reach and engage, even, of course, pre-pandemic. So obviously medications, certainly not the only issue, basic needs and other concerns, but medications, a primary concern. How are we going to be able to continue to, have folks access their medications, especially with, the barrier of not being able to do a fraction of the face-to-face services and outreach that our organization really has been built on. A lot of care management out in the community. Historically, about 70% of our services, even including the office-based, 70% are provided out in the community setting. Fortunately, and obviously we're talk pharmacy a bit today and how that relates to medications, but we've partnered with the pharmacy, Genoa, for nearly 20 years to bring the full range of services, pharmacy services, especially into our larger clinics. And so, as Dr. Hedges said, we've also been aspiring to integrated models of care for many years. And so the pharmacy's been a real key partner in those efforts. So I think that, of course, gave us a great advantage to start as we began facing these challenges head on. We needed to find ways to be more flexible, particularly throughout our service, our clinical operations, accessing services, accessing medications. And in some cases, we had to get really creative. And, some of the tools that were kind of at our disposal, really sped up. I think as you were saying, Dr. Hedges, the use of data, working with the pharmacy, for example, on reports around medication adherence and medication possession and pickup and those kinds of things. We actually, we started with 100% assessment of all of our case managed clients to determine the best mode to reach them and serve them. So that was helpful. And also identifying kind of what are their, sort of emerging basic needs as we were getting really deep into the sort of the early dark days of the pandemic. There was a drastic increase, of course, in telehealth, including the use of the telephone without video. So for those who don't have laptops and all those kinds of things, we had a chance, and a shot to engage some with just the telephone. Fortunately, Ohio and other states, did some emergency rule changes to allow for some of those greater flexibilities. I did want to mention, mailed medications really skyrocketed for us. We began, relying on data and reports, and then that kind of told us in some of our assessments how we could begin to, make sure medications were deployed in a way that had a higher, the highest chance of our clients being able to receive them. And a couple other things worth noting related to the pharmacy. We put our heads together and did some pretty creative things around pickup stations. We had clients and staff not able to access the insides of offices, so we did some creative things down on the exteriors and some rooms off the side of the building I didn't even know we had. So we were able to do some things there to make access and pickup of medications safe and to keep that access easy. People could drive through and drive up, and we had that working pretty well as we kind of rapidly deployed some of those strategies. So last thing I'll mention, we created a van for our nurses and equipped it and used it for mobile injections. And, as you've heard me describe, the lion's share of the populations that we serve, homeless folks who with severe mental illness, for example, that ability to deploy those long, acting injections was critical for many, many clients. So that was a way that we were able to work with the pharmacy and, again, put our heads together there and work out some strategies for being able to continue to, deploy those long-acting injections. So it was a great support to us to help us, and kind of rapidly, as we all had to respond rapidly and develop some of these tactical, strategies.
Yeah, first of all, I want to say thank you to both of you for continuing to be amazing partners with Genoa Healthcare, but recognizing that a completely virtual solution is not going to work for all consumers. It's just not. Jeff, you mentioned the homeless population; they simply don't have access to it. And for your creativity, right, and innovation in a rapid time frame to be able to get the services that are so desperately needed continued. And you touched a bit on my next question. So if we can go to the next slide, which was how is an on-site pharmacy helping you stay connected? A bit partial to this question being a pharmacist, but how can you talk, Dr. Hedges, about how the pharmacy has really helped you connect? We talk about just about every appointment, whether it be telehealth or in-person visit, has usually some sort of medication component. How is your on-site pharmacy giving you the information as both a prescriber and as a clinic to make sure that people are staying on their medications?
All right, that's a great question. And I really echo many of the observations that Jeff made about being nimble in our transition over the last couple of years. Even within the context of those last 2 years, the things that we were doing in the very beginning and the things that we're doing now are not the same. So the ability to be nimble has changed even during the period of the pandemic. And having clinical care partners to help us think carefully about good solutions is huge. So one of the areas that I would highlight as an example of that is our Clozaril clinics or our injection clinics. Both of these are great examples where you have to figure out solutions where you can do a closer, more personal contact. If you're given an injection or if you're monitoring labs for Clozaril, you have to see patients in their one-on-one basis. And how do we think about doing that? Well, the pharmacy was really a huge help in trying to figure out or work with us and trying to come up with some of those solutions. And the most important thing is just the ability to sit down with your local pharmacist and think together with the resources we have, how do we ensure we provide the best care that we can to the clients that we're serving? And they're engaged in trying to ensure that we have strong medication adherence with the folks that we're serving. So that's one example of areas where we've seen some huge improvement. The other area, which has been, which is sort of hidden, I think, sometimes, but we're also interested in primary care integration as well. And that is working with our general pharmacists, not only with their psychiatric medications, but with their other primary care medications, and ensuring that there isn't a gap in treatment for those, particularly for our adult patients, and particularly with our patients with severe and persistent mental illness. The prevalence of other diagnoses such as metabolic disorders or hypertension or pulmonary disorders are high. And those complications can increase the chances of entering into the hospital if we're not coordinating those medications. And so a lot of times communication from our pharmacists to like case management services, to our ACT teams, that there are problems or gaps in therapy with a person's diabetic medications can bring us to knowledge to help intervene with a more successful outcome than allowing that disease process to continue to unfold and a person end up in the emergency room, for example. So those are just a couple areas off the top of my head where that on-site pharmacy integration is huge. We have 3 pharmacies within serving our larger area, and that allows us to kind of spread that those solutions across multiple different service arrays. And those are just the examples for our outpatient services. You know, figuring out how we're doing solutions for our medication-assisted treatment for our addiction services or our child residential programs. These are all integral parts of just engaging in those conversations. I did want to highlight, though, before, because I'm sure Jeff has some great feedback in this area as well. One of the challenges from our previous question that I think we may get to another slide to think about this is that we still haven't quite figured out yet to be well. But so you were talking about value-added contracting, and a huge number of the measurements that we have to live up to are the HEDIS standards that involve metabolic monitoring. Well, if you heard the introduction, I'm also the laboratory director for our organization, and getting people in timely labs to be able to monitor that has proven to be a bit of a challenge for us. And so one of the ways we connect that is in conversations when people are coming in for their pharmacy services, if that's an option available to them. So there are different ways to look at an economy of scale when you bring some of these services together. Just a thought. Jeff?
Yeah, you're speaking to my heart, Dr. Hedges, right? So as a pharmacist, we long to be part of the the health team, right, of the care team. And that's really what brought me to Genoa Healthcare and what continues me working here doing the work that we do every day, and that we have the ability to make meaningful, timeful interactions for health outcomes for people, right? Right when they're in the visit, we can say, hey, this medication is not covered. Can we try something in the interim while we attempt to get the prior authorization? You pointed out lab monitoring. People see their clinicians sometimes 3-4 times a year, but they see their pharmacists usually 12 times a year to fill their refills. We can give those messages. We can make those suggestions when we're talking to them. So thank you. Thank you for recognizing the benefit that pharmacists can have in the care team. Did you have something to add to this? Go ahead.
No, I was just going to chime in. There are also other hidden advantages as well. So just something that was near and dear to my heart just this week is we are in the process of evaluating upgrades to our electronic health record. And part of that connection is how do we interface with electronic MARs. In a unique way of thinking of collaboration, we actually brought in the general pharmacist into our conversation about what is the best way to streamline so that we have the most effective product in terms of the point where you have orders, to when they go to the pharmacy, to when they're posted in the EMR, to how they're monitored. And so that's just not a level of value-added services that you can get if you're looking at other retail pharmacies. So just an added thought. Sorry.
You're taking medication and you're not involving a pharmacist who's going to be the one who delivers that medication. You're missing a big piece of the puzzle. Thank you. In the interest of time, let's move on to the next question, because I think these are all bleeding into each other very nicely. But how do on-site pharmacy services give you an edge in an increasingly competitive market? So what does having a Genoa pharmacy or an on-site pharmacy mean to your consumers? Jeff?
Yeah, I think from the start, we made a very conscious, intentional decision to locate our pharmacy in Genoa, which was not Genoa at the time, many years back, but same company but different name. And we made the decision to locate it right smack dab in the middle of our psychiatric and medical services clinic. That was very intentional, and we didn't want to just settle for having just a pharmacy that would provide what any other pharmacy would. We wanted to push the envelope a bit and get some bigger benefits and advantages. So we were really out to foster initially those relationships between the pharmacy, our clients, and of course our staff. Honestly, we wanted to create the dynamic that would also push the pharmacy to really get to know our clients and be highly educated in a specialty way about the barriers they face, and not only just about medications, but beyond that. And I guess in essence, we thought it was important for the pharmacy to be immersed in part of the culture and a true partner that was part of our mission, and that would help us bridge the gaps in many ways that we couldn't otherwise. And we continue to work with community pharmacies and retail pharmacies as well that are some of our clients are connected to, but they just can't necessarily provide some of the things I just mentioned. And when they're located right in the middle of the psychiatric clinic, the synergy is tremendous, and you almost can't miss at times when you have the right people involved and with the right intentions, and everybody's here for the good of our clients. You just see some of the wonderful things happening, those synergies that otherwise we were missing before we had pharmacy as part of our clinic. And otherwise why do it without getting those advantages.
You hit on a big part of what we try to do differently, which is compassionate pharmacy care. There's some really great pharmacists out there who don't understand the different SPMI states that people are experiencing, why they may not be picking up their medications. They may not understand that they have to beg and plead or rely on one transportation to bring them to their appointment, and they don't have someone to bring them to a pharmacy afterwards. It's solving for those unique problems that the consumers have to get those medications into their hands when we know we have a very small time frame of window for them to take them properly. Dr. Hedges, anything to add about that?
Yeah, I would add two different components just to add to Jeff's observation. The first, I just really want to highlight, particularly in the behavioral health component, the importance. I really can't state it enough. The importance of that personal relationship in the context of the clinic itself. Unfortunately, and it saddens me to say this, but many of our clients have not had the best interaction with community-based pharmacies, commercial-based pharmacies. We have some of our clients that have been asked to leave pharmacy services when they're trying to get their medications. And to be honest, some of our clients, because of their illness, may not always be the most pleasant to be around because of the struggles that they're dealing with at a particular point. And so I recognize that. But in all of our general pharmacies, the pharmacists make it a point to get to know the individual clients, even the most ill or delusional clients. They work really hard. And one of the things that's really impressive is that we've had a couple occasions over the years where some of the behavior that occurs in relationship to the pharmacy or the pharmacy staff needs to be addressed. And unlike our experience in other pharmacies, our experience with Genoa is that the staff there want to partner with the clinical team for a solution that has a positive impact on that person's life. And they're intentional about engaging the clinical team about how do we think through to ensure that this person continues to get the best services they can. The other thing that particularly related to this question, which is a little bit different than what I was just mentioning, but the edge on an increasingly competitive market. Well, so one of the biggest things in Kentucky, at least, in terms of the managed care market is the amount of days that are spent on an inpatient level of care. And frankly, that's not just inpatient for psychiatric services, that's inpatient for any level of care. And in referencing to what I was talking about under the last question, the ability that we get reports where we can see gaps in therapies, that's important, and that's helpful when it comes to monitoring the population health. But again, the most important thing is that the pharmacist knows that they haven't seen so-and-so and they're due for their medication, and they don't wait for a report to come out. They are communicating with the prescriber, they're communicating with the case manager, they're communicating with the ACT team, saying, so-and-so was supposed to be in here this week to pick up their medication. I haven't seen them. I'm just a little bit worried about what's going on. And that ability to impact when there's a gap in therapy for whatever reason is huge. And we've discovered some really fascinating things just at that piece of information, and then digging into what's going on with that particular individual that stands as a barrier. This kind of interaction that allows us to intervene as early as we can is a huge competitive advantage for us in our market.
Thank you for that. Yeah, this is warming my heart, this conversation today as a pharmacist. Again, it's what I think everyone who is a pharmacist wants their profession to be like, which is to have these meaningful relationships with consumers. And unfortunately, the volume at some other pharmacies, you're just not able to. Those relationships, I used to say, we have lots of reports at your disposal, but you'll know about things before because I'll recognize it as your pharmacist. And for you to illustrate that just speaks so highly about that, the consumer-pharmacist relationship that you just can't get unless the pharmacist is integrated into your team. Thank you for that. So we have another question here of how does your on-site pharmacy help you measure and deliver results in your programs? Can someone advance the slide? There we go. So this is a bit of what you were talking about, Dr. Hedges, of when we're talking value-based reimbursements, you mentioned HEDIS measures. I had the chance to be part of 2 value-based programs with 2 of our centers in Rhode Island, and 3 of the 5 measures of success for shared savings were pharmacy medication adherence. So how do you measure pharmacy medication adherence if you don't have an on-site pharmacy? And I think the answer is you can't. As someone who's prescribing, Dr. Hedges, how do you even know if someone ever picks up their medication if it's not at your pharmacy?
Well, that's really an interesting question. So we actually did a small study before the pandemic. So this is a little bit before the particular events that we're talking about now, where we were doing medication monitoring through urine samples. And so we were basically asking, what is the person's kidney telling us in terms of what medications they're on or not? And it was fascinating to see the results of that particular thing. So one of the examples is that if you ask our prescribers, what is the rate of individuals that are not taking the medications you're prescribing? Because prescribers, and I'm guilty of this as myself, prescribers like to think that, well, I know when somebody's not taking their medicine. I can tell. I know when they're not taking their medicine. That's not the case. Turns out that upwards toward 25 to 30% of the populations that we were looking at, in fact, were not compliant with the medications that we were prescribing. When we asked the prescribers, they were saying only about 5% of the patients that they were prescribing were not compliant with the medication. So that was a big gap. The other area was related to, well, do you even know what medications your client is taking? And of course I know. I do a medication reconciliation. They tell me the medications are on. Well, it turns out that, again, about another 25% of our folks are taking medications we didn't even know that they were on. They didn't disclose in that information. Well, having the pharmacist engage and check to see what prescriptions are getting filled in other areas, to look at the gap in services, to track that information is a great way, short of testing people's urine in that process, to get at that kind of information in a more consistent way. And it's proven to be really valuable for us, both in terms of knowing what other medications they're getting from other prescribers, as well as their pattern of being able to refill their medications on a regular basis. So it's a huge advantage for us.
Yeah. Jeff?
Yeah, I'll just add, Ohio, for example, has not progressed very much into value-based programs in behavioral health. However, we are fast moving into managed care models of care, for particularly with Medicaid programs for behavioral health. So we know it's common. Some organizations like Greater Cincinnati Behavioral Health have participated in some smaller value-based programs. So Kevin, as you said, it's coming, irrespective of where you are, it is in healthcare. And I mentioned earlier, our roots are really in serving those with the most severe mental illnesses and complex needs throughout our community. So as Dr. Hedges said earlier, we also have 7 assertive community treatment teams, ACT teams. We apply that ACT model to some very specific efforts, such as our homeless program, our felony and municipal mental health court teams. We have a forensic prison reentry team that is built under an ACT model. Of course, we have IDDT and our first episode psychosis programs. So between, those types of models that I think many of our listeners today or participants in the webinar are also stewarding those kind of programs. And then you add in things like CCBHC, which is a big wave across the country. And we were the first in Ohio to receive that, and many others also are becoming certified in that model. And of course, just some of the longer programs that SAMHSA has helped us with around integrated care. So the point being there that, we're all aspiring to higher levels of outcomes, and the accountability that's built into these models certainly for client outcomes has really raised the bar. So, we need the high partnership with the pharmacy. It's in some cases we're providing medication monitoring and support and engagement, in some cases multiple times a day for some clients. And some of the tools and reports that Genoa has that we sped up, quite frankly, during as the pandemic was launched. And as Doc said, sometimes you think you know what's happening anecdotally, and as you ask questions and dive into cases and things that are happening, and sometimes it's erroneous information when you really look at the objective data. So just encouraging the use of the tools, and they're not always perfect as they start off, but refining those tools. And some of the things that that's been helpful, the medication, the meta analyzer that Genoa has been developing, the adherence reports. We were doing even some rudimentary pickup monitoring for our pickup station that we developed with Genoa, as we had to mobilize that pretty quickly to make sure we were able to be accessible on the sort of on the ground level of the buildings. And just having that partner, we can work creatively and timely, for these emerging clients' needs is really important, so that we can tailor things to their needs and the parameters involved in the clinical situation. And it's important, especially as we're focused on things like Doc, I think, reference hospitalizations, discharge and follow-up. For us, we work very closely with the jail, and we have unfortunately a large part of our census, that engages in the jail throughout the year, and of course crisis stabilization. So having that timely response and being able to coordinate, collaborate quickly to tailor to those situations has really become the expectation, and it's a high bar, but I think most of us are able to get there when we have the right things in place.
You brought up one of the most important parts of a Genoa clinic relationship, which is we tailor our services to your needs. Unlike retail pharmacies, they have their own operating model, and the consumer has to operate within that. So if you have a program that you need us to support better or differently, or reporting that you need, you simply just ask, and we will either find the tool that we already have developed or work on developing another tool. That's the most important piece. Is it really works best when it's a two-way street, that it's a true partnership. You talked about coordination of care, Dr. Hedges. We do things like hospital discharge programs. So we work closely with local hospitals to say, as someone is leaving the hospital, let us bring their medications that they need to walk out with to their hospital bed, so that there's no question that they walk out with them. And that way we can share that with their clinic partner to say, hey, patient so-and-so was discharged on these medications, so you have a chance to evaluate them even before they come back in for those 7-day or 30-day follow-up measures. We do jail diversion programs where people can leave the jail system with the medications that they need to be on, and we'll continue to mail them as long as that prescriber is willing to prescribe for them before they get back into another health system, to make sure they don't turn right back around into the jail or hospital system. So it's all about working with your clinic's clinical goals and finding the solution with the pharmacy that's going to work to meet those outcomes. Great. All right. Well, that is the last question we had today. So we're going to move to discussion from the audience. So let's move to the next slide, please. We're going to close it out with a poll, and we're also going to allow anyone to and send some questions in the question box. So on the right of your screen, or wherever you've placed that little dialog box, you'll see some questions, and you can go ahead and ask a question. And we have one that came in here. With prescribers working remotely, how are you handling Ames testing and other assessments that require in-person observations?
So I'll tell you our solution, which is not a perfect solution, and I'm certainly open to hearing how other individuals manage this. So for 7 counties, we've gone to sort of a hybrid approach. And so we require Ames testing to occur on a regular basis, on at least on a quarterly basis for our organization. And we are allowing for the documentation of that Ames testing to occur via telemedicine. So you have to have a camera, it's not telephonic, via telemedicine, so long as the prescriber or the nurse is documenting that the Ames examination had its limits associated with it because it was done via telemedicine. But we require that at least annually we have to do a face-to-face Ames test to validate our telemedicine findings. So we're trying to find a compromise solution that addresses the legitimacy that you have to do an Ames testing in person, but recognizing that some of our clients are uncomfortable still coming in to do face-to-face services, and we don't want to just not do some monitoring of abnormal movements. So we do what we can in the context of telemedicine. We document the limitations associated with that, but we try to put into place, at least on an annual basis, a validating test on a one-on-one or face-to-face services. So that's how we've approached the solution. And then I'm certainly interested in hearing other ideas.
Yeah, you brought up something similar when it comes to long-acting injectables, right? So we saw a quick downgrade in the use of long-acting injectables at the beginning of the pandemic. Many states allow pharmacists to administer those. So if there is not someone available in your clinic and someone needs a long-acting injectable, if the state allows it, that's something Genoa pharmacists can do for you. So it's finding those solutions, the innovative ways to keep people on the therapies that we know work best. Jeff, did you have an answer for that question? Or?
Well, I will say that right now we are in the process of scheduling all of our psychiatric appointments in person. I think we're measuring right now around over 98% of those. And will that, continue kind of into the future? Probably not, as we begin to assess and work with, people on, what is the best modality for them. But I think because we were really, filled with a lot of concerns around, such a long period of time with not having, in-person contact with the prescriber, and sort of the striation of the population we serve, we made the decision that, we had a lot of catch up to do. And that, I think that question is just one of many things that we wanted to, and consultation with our medical directors and our chief medical officer, so that was a big decision we made as we began to ramp services back, different services in terms of the in-person issue. We started with psychiatric appointments.
That's great. One question did come in that I think probably would be more for me, which is, does Genoa charge extra for any of the additional services through the pandemic, like medication packaging and medication delivery? The answer is no. We've never charged for those services because it's the right thing to do for the population. So I think Jeff mentioned very early on in the conversation that medication mailing went up. It went up about 80% at Genoa, just for the need of people not having either the want or the means to get into the clinic. Our dispill packaging, which is where the pharmacist and technician packages their medications according to morning, afternoon, evening, and bedtime, we provide that service for free if consumers or prescribers want that. It's actually really good. Jeff brought up his assertive community treatment teams. I can't imagine running an ACT team without having the dispill packaging, having been a pharmacist that served those types of teams for years. We're able to make same-day adjustments often to the bubble packs, depending on what time of the day the order comes in. And we keep talking about meaningful, timeful interactions, and that's just one that pops in the top of my head. That's something that we can uniquely do to service those types of communities who often need those acute medication changes. Good questions. Everyone's being quiet here on the questions. We've only gotten 2. Anyone else have any questions? Okay.
I will seize the opportunity to talk a little bit about areas that we are interested in continuing to explore so that we can sharpen these areas. So one of the things that have been an interest to us in terms of figuring out how can we do a better job. So prior to the pandemic, when we were all in the same building, the patients and Genoa and our prescribers and our nursing staff, our clinicians, if there was a question that came up at that particular point in time that we wanted to seek a pharmacist consultation, we literally could just walk down the hall and have a direct conversation with the pharmacist who's taking care of that particular individual and come up with the best solution. And it could be anything related to prior authorization issues or interactions with other medications that are not being prescribed by us, or those kinds of questions. There's a huge added benefit for us. And many of our prescribers love the ability just to be able to engage in that kind of dialogue or conversation. If our prescribers are in the same building again with the pharmacist, then that still works pretty well, regardless of whether or not they're doing telemedicine or not. But if the prescriber is off-site in using telemedicine, now it becomes a little trickier. And it's been an interesting question for us to think through. How do we build a mechanism for communication that is as robust as walking down the hall and talking with a pharmacist, and still manage to protect PHI in the process? So you can't really do text, you can't really do email, unless you do secured email, you can do that. But then that means they have to be looking at their emails to be able to see that. So this has been an active conversation with our pharmacists about how do we build that sort of one-on-one live communication in real time. And that's just been a fascinating conversation. I don't think we've completely solved it to my liking at this particular point, but it's been really engaging to try to think about how do we figure out the best way to have that sort of live experience in interacting with the pharmacist in a telehealth environment. And
we're developing exactly what you're talking about, Dr. Hedges, which is a way for you to virtually connect with the pharmacist through a web camera. So the closest thing to walking down the hall. We're hoping to have that roll out soon. It's with supply chain issues, been logistically difficult to get as many webcams as we require, but we're developing that because we see the need for that too. We also have to shift as a pharmacy company if visits are going to remain virtual so that we can connect with our consumers as well. So thank you for pointing that out.
Well, and from our perspective, and I'd be really interested in hearing Jeff's thoughts about this. Even if our infectivity rate drops to 0, I mean, if the COVID virus essentially goes away, there's no going back to the way things were before. Many of our consumers enjoy the options of being able to have a variety of modalities to connect with their therapist or their case manager or their prescriber or their nurse. And so our practice has forever changed at this point. And so thinking through how do we navigate our best practices in having face-to-face services as a viable option when indicated, but also being nimble enough so that when a client chooses to connect with their prescriber or connect with their nurse or connect with their therapist or their case manager via a telemedicine service, that we are robust enough to mix those two on the fly in a way that continues to provide those services. And that bleeds over to our relationship with the pharmacy as well.
Yeah, I believe we can be a big solution to that piece, right? As things feel more and more disconnected, us being part of the handoff to after your appointment ends to when the treatment begins, and then giving feedback to the prescriber. I know that we are already a part of that solution, and we continue to working with great partners like yourselves on just furthering the strength of that relationship. You know, I liken what you said of telehealth is not going away to DVDs and Netflix and going to the movies. I don't have DVDs anymore. I watch most everything on Netflix, but if something comes out important to me, there's nothing beats the in-person movies. So I love your passion for what you guys do. And I'd like to end today with a poll, and I'd like everyone to, in the chat, we're going to end on a positive note today, and our end poll today is going to be what brought you into behavioral health care? So I'd like everyone to just type something that made them go into behavioral health care. Everybody can't be quiet here. We're talking about the strength of virtual relationships. You got to type in the chat box. Jeff, you want to start off? What brought you into behavioral health care?
Yeah, thanks, Kevin. And again, thanks for having me today. And it's been a pleasure listening to Dr. Hedges as well. His expertise, in some cases, things that I would not be able to comment on. And so I appreciate the opportunity to be with both of you today, and of course our participants. It's an easy answer for me. I started out with the same organization that I'm with now, Greater Cincinnati Behavioral Health Services. I was in my early 20s, going to date myself now, but my first job was working second shift in one of our residential group homes. And at the time, of course, the deinstitutionalization wave was continuing, and our mission was really, clear at the time to, help folks who were coming out, whether it was by choice or not choice, but many who had been institutionalized for a long, long time. And, that's the experience. We didn't have new employee orientation and elaborate training programs then. So I learned from the 16 residents, most who were diagnosed with a psychotic disorder or some very severe mental illness. And of course, with all the other disparities and, institutional, behaviors and things that they had unfortunately taken on. Medications, as we were talking a lot about today, were terrible. I'll just be frank, in most cases. And of course, in a lot of cases, they were what we had, and they were enough to mitigate at times, some things as well. So I want to be fair with that comment. However, my experience there, in close quarters, day in and day out, I learned so much. Unfortunately, some bad things about mental illness, but also some of the inspiring and amazing things that we see in recovery as people are able to get their lives back and progress forward. And then I'll just mention the other thing that really struck me was the interaction with families. So for those of our clients who did have families, just seeing up close and personal the devastation that occurs and the confusion, and very commonality with all the clients who what I engaged in with their families. That's what I learned, and it really affected me as a young person. And today it fuels me more and more every day to help advocate and help folks again get their lives back. So thank you.
Thank you for sharing that. Some great ones coming into the chat: to have long-term relationships with patients. I love people. Patients with SPMI are an ignored subpopulation of great need. With simple efforts in what we do, we can change lives. I mean, what more can we say than that? So I'd like to thank Jeff O'Neill and Dr. Scott Hedges for joining me today, and all of our participants listening on the webinar. We hope you found this helpful today in talking about how an on-site pharmacy can really help minimize the gap between the telehealth appointment or the hybrid model appointment to get the consumers the care that they desperately need and deserve. So I once again thank everyone. Please join us for our next upcoming webinar. You should receive information on that soon, and we'll see you soon. Thanks. Take care, everyone.
Thanks.